meeting. On account of inauguration, we'll be stopping our transmission for half an hour to 1 hour. After that, we will resume transmission. The chairpersons may please leave the dais and we can resume the duties once the inauguration is over. Sorry for the inconvenience. One more announcement. For tomorrow's Hall A and Hall B, many of
हाँ निखिल here. We are doing it. We are doing it in a minute. You are getting the picture now. So I will hand over the mic to Dr. Satish Jain now. Yes. 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 Of course.
इधर से हाँ इधर से
Hello.
हाथ में लगे मेरा
Hello. Hello.
अभी चल इधर आएंगे
Hello.
Hello.
Yes, Satish.
Yes, sir. Can you hear me?
Yeah, we can.
So good afternoon, everyone. It's been a matter of honor and privilege for me to be here in our national body meeting for this live surgical session. I'm really thankful to the organizing team, especially entire team AOI, especially Dr. Sanjay Agarwal. He is like elder brother who has given this opportunity. Thank you so much. Are you getting the picture, sir?
Yeah, we are getting the picture, but reality is little down.
What picture? Scan?
Yes, CT scan.
Okay. So this case is a young lady having bilateral pansinusitis, had a long history, almost 2 years, recurrent symptoms, has taken several times, medical treatment, steroid courses, steroid sprays, many things, but couldn't control the symptoms and getting the symptoms again and again. This is the typical how the chronic sinusitis is diagnosed. You know, CRS is basically diagnosed on the basis of symptomatology. When the symptoms, the major symptoms persist for more than 12 weeks, then you can categorize them into the chronic sinusitis category. And then it is the diagnosis is supplemented by means of endoscopy, where you see the polyps coming out. And then finally we get the radiology done for the purpose of surgery, so as to know the anatomical details. So role of scanning is very limited in terms of diagnosis. This is to facilitate our surgery to prevent complications and to do a sort of complete surgery. Once it comes to scan, like when it comes to order a scan for sinusitis, ideally we need to order non-contrast fine section, like we order at our center 0.625 mm, multiplanar axial coronal sagittal in both bone and soft tissue windows. That will give you ideal three-dimensional details of the paranasal sinus labyrinth.
What thickness will you advise?
What sequence?
What thickness?
Thickness 0.625 ideally, and now most of the multiplanar multi-detector CT are able to give this. So the more finer the scans you have, less are the chances of missing something, because in sinuses we know the millimeter distance can make a huge of a difference. The reason being why the CT is so important in fine section, to have a full three-dimensional knowledge of not only the anatomy of the paranasal sinuses, but the surrounding relationship with the surrounding structure. Like we know, sinuses are surrounded by orbit and skull base all around, and a millimeter difference can change the life of the patient. So the margin of safety is very low. So goal in sinus surgery, once it comes to surgery, is to carry out a complete surgery, the same time preventing complications. So here, like in this patient, we have a scan, and we have this particular scan 4 millimeter space slices, and this happens very often when we get a patient of sinusitis with already having a scan in the hand, and you really don't feel like getting another scan done if you are good enough doing that on that basis. So I am going to take you through the important anatomical details of this particular patient in brief. Like this particular patient, we have coronal sections, and the first section what we are having here, it will take almost 5 to 10 minutes to start the case. Sandeep, ready? Marocel, होगा ना? बोलना. Organize. So these are coronal section images. Can you focus on this? Are you getting this focused image? That's the first coronal image, and what we are looking at this image is the frontal bone, the outside skin, and the nasal bone, a part of the nasal bone, glimpse of the nasal bone coming into the picture. Can you see? And this is the cartilaginous part of the nasal septum with the nasal ala. As we move, now see the moment we move to the next picture, we are jumping by 4 millimeters, roughly 4 millimeters, and see the sudden dramatic change in the picture with the frontal bone pneumatized into two spaces which are separated by a septum, intersinus septum, which is almost always eccentric. You can see over here as well. And there is a full blown picture of the nasal bone with the frontonasal processes coming into the picture. Can you see over here? Yes. And here in this picture you see, here is the upper bony part of the nasal septum, perpendicular plate of the ethmoid forming the upper part of the nasal septum, and same here the cartilaginous septum below and the ala on either side. Now, what we see here, the difference between the previous and this picture is, previous was showing the nasal bone. As we go behind, we are going behind. What we see is the beak of the frontal sinus. The beak forms the floor of the frontal sinus, and as you see from anteriorly, it forms a part of the anterior wall as well. Here you can see very well the beak forming the floor of the frontal sinus. Now, knowing the fact that the frontal sinus is drained from behind through the frontal outflow tract, the frontal recess, that is from the posterior part of the frontal sinus. So as you go from anterior to posterior, you see in the next section still the part of the beak being there. Can you see? And this is like the beak is going. In the next section you see there is no floor. So you can say this is the posterior part of the frontal sinus, which is going to go ultimately draining through the frontal recess from behind. Okay. Now at this level of the beak, we see two cells going above the level of the beak. Can you see? So there are variety of cells in relation to the frontal sinus drainage pathway. There are certain cells which are narrowing the frontal sinus pathway, drainage pathway from anteriorly. There are a group of cells which narrows from behind. So these are the anterior cells going above the level of the beak, which Kuhn has classified. That's a very clinical classification that gives you an idea that how the degree of difficulty the surgeon going to have in addressing these cells which are going high up. So it looks like type 3 cells which are projecting into the frontal sinus itself above the level of the floor. Can you see here? Now as you go behind, now the frontal floor has gone. Can you see? And what is there? Going above both sides, looking like frontal sinuses itself. Can you see this? This is the last part of the frontal sinus, and see it is going beyond, laterally and beyond and above the level of the orbit, and that is what the supraorbital pneumatization. This is a very, very important anatomy that we need to understand and should not be mistaken with the frontal sinus. See the next picture. Can you focus here? Are you getting this? Yes. See the pneumatization on both sides above the orbit looking like frontal sinus, but it cannot be frontal sinus at this level when you see the beginning of the maxillary sinus into the picture. When you see the maxillary sinus in the picture, that means the section is so behind. The level of the section is so behind, it cannot be frontal sinus, and it is always the supraorbital cells, supraorbital recess, supraorbital pneumatization. And this can be of varying amount. Sometimes you see a very little supraorbital pneumatization, and sometimes we have seen even going towards zygoma and pneumatizing the entire zygoma in continuity. So this patient has a huge supraorbital pneumatization, you can see in the picture. This is behind the level of the frontal sinus. We have already left the frontal sinus behind. If you see, go back to this, see the difference, and this is behind the level of the frontal sinus where the roof is being formed by ethmoidal bone. Now at this level we see the pneumatization and complete opacification of the frontal recess and the supraorbital pneumatization. See the complete pneumatization bilaterally. Next picture, what you see coming into the picture, as I said, the roof is formed by the ethmoid. As you go behind, this is roughly, I can say, when you see the level of the beak, the beginning of the ethmoidal roof, the beginning of the cribiform plate is roughly a centimeter behind. And this is very important anatomy as you are working sometimes close to the frontal sinus, close to the beak, and you are always worried of, if you are working medially, damaging the cribiform plate. So it is almost always a centimeter behind the last part of the frontal sinus opening. Can you see here? Now the cribiform plate forming the roof of the ethmoid coming into the picture. That's the beginning of the cribiform plate. And at this level we see some opacification. See this hyperdensity, and which looks like, which is very, I would say, not uncommon in this region, in the ethmoidal and the frontal region, are many a times osteomas. So it looks like a very small osteoma attached to the roof over here. So we'll see while we operate that how it is attached, and we'll definitely remove it. Now going to the, as I said, when the supraorbital pneumatization, you see the beginning of the maxillary sinus is there in the picture, and at the medial end of the maxillary sinus, can you see these? That a sort of opacity extending, it's actually a normal opacity which houses the nasolacrimal duct from the inferior-medial part of the orbit. Can you see here? So it's quite anterior anatomy, we all know how anterior the NLD is, and that's the level of this section. Now as you go behind, you see the ethmoidal cells in the picture? As you go behind, the biggest ethmoidal cell which we come across in this picture, in the coronal section, it's very clear, is the ethmoidal bulla. Can you see? Now if you go back to the previous picture, at the beginning of the cribiform plate, there is the most important anatomy which we should always keep in mind while operating, is the middle turbinate. The middle turbinate, we all know, is a very important relationship to orient the surgeon throughout the surgery, and another implication is, it's the first part of the middle turbinate goes high up to get attached onto the cribiform plate. Okay? Now see the full blown picture of the cribiform plate over here. Can you see?
Yes.
These are two anatomical structures on either side of the septum. This is the first part of the middle turbinate, which actually is lying in the sagittal plane, going high up to the cribiform plate and taking an attachment over here to the, most precisely, it gets attached to the junction of the horizontal and the vertical lamella of the cribiform plate. Okay? This is important for two reasons. Number one, while we are operating in this corridor, we should keep this middle turbinate as our medial limit. We all know as we go medial to the middle turbinate, we can hit the skull base above. So that's something which prevents us entering the skull base as an anatomy which is very, very easy to identify and follow. And number two, when it comes to dealing with this structure, we have to respect it to the highest level. As it gets attachment to the skull base, any false or any forceful movement of the middle turbinate may get you to the fracture at the level of the cribiform plate, which can be a disaster. It should always be respected and taken care of. Now as you go behind, can you see the bulla ethmoidalis on both sides? And that's the lower part of the uncinate we can see over here, which takes an origin here or takes an attachment here to the inferior turbinate. Now as you go behind, the inferior turbinate is uncinate is two parts, the vertical and horizontal. Now see, as you go behind, the horizontal part of the uncinate process, very, very clear. Can you see here? And in the axial sections, you get the best anatomy of this osteomeatal region, where you can see very clearly the relationship of the bulla uncinate, infundibulum, and the hiatus semilunaris. And for this, the best section is the axial one. Okay? Now, as we move behind, we are in the anterior ethmoidal roof, and that is formed by the cribriform plate. You see the cribriform plate here, and at the same time, if you look into the orbit, the adjacent orbit, we need to take, or we need to correlate the intraorbital structures to our sinus structures to get another landmark for an important structure, that is anterior ethmoidal artery. This anterior ethmoidal artery here in this case is very important. The reason I am telling is, whenever you find excessive or extensive supraorbital pneumatization, you have to be careful that you are going to find a prominent anterior ethmoidal artery, which you have to obviously respect and preserve. If the anterior ethmoidal roof is over pneumatized, simply maybe this supraorbital pneumatization or any other pneumatization, since this artery or this vessel runs through the bone of the roof of the ethmoid, if it is over pneumatized, the bone ultimately is going to be thinner, and then the vessel is going to be prominent, and many a times we have seen this running without the bony covering. We call it as the artery running in the mesentery. So we have to be prepared once you see the supraorbital pneumatization to deal with this. Now, another important thing what I want to relate over here, we have been seeing this supraorbital pneumatization following posteriorly. When you follow this supraorbital cell behind, that will relate surgically as well. The posterior border of the supraorbital recess is the anterior ethmoidal artery. Okay? So when the supraorbital recess ends, the anterior ethmoidal artery comes in the picture. That is one of the important ways to identify the level of the anterior ethmoidal artery. That if you have a supraorbital pneumatization, go caudally where the pneumatization ends, and that's why that is bordered by the anterior ethmoidal artery. Similarly, you can pick up by looking at the intraorbital structures. Can you see inside the orbit over here?
Yes.
That is the medial rectus muscle, superior rectus, and at this angle is the superior oblique muscle.
Yes.
See here in the next section, medial rectus, superior oblique coming closer.
Yes.
These two muscles which are running at this level, in between these two, where these muscles come in contact, see this, they come closer here, and that's the point where this artery exits the orbit. This is a branch of ophthalmic artery which exits inside the orbit, given off in the orbit, and exits the orbit from its medial wall at the junction or at the confluence of this medial rectus and the superior oblique muscle. And see this confluence and see this beaking. Can you see the beaking of the medial wall of this? This is exactly the level where the anterior ethmoidal artery leaves the orbit. Now, once you find this anatomy, now this is very, very important to understand, which has an important surgical correlation. The moment you see the anterior ethmoidal artery, assume that you are in the most posterior part of the anterior ethmoidal roof. The moment you leave the artery behind, if you are coming from anterior to posterior, moment you leave the artery behind, your posterior ethmoid begins. So, at this level, what you see the previous level, the crista galli?
Yes.
We left the artery over here, and see the next section. The roof of the posterior ethmoid begins, which is more thicker, more flatter, and this is how the transition of the anterior and posterior ethmoidal cavities which we can make out. Now, what is the surgical correlation? What is the importance? See, in the previous section, as long as you see the cribriform plate, your middle turbinate goes about to the cribriform. Okay?
Yes.
The moment the cribriform is over, see where the middle turbinate is going? Laterally to insert on the lamina papyracea. So that's the second part, we call it as a ground lamella or basal lamella. This is anatomically, embryologically, functionally very, very important structure separating the anterior from posterior group of cells. So, why it is important surgically when we relate with the anterior ethmoidal artery? Sometimes you have a massive disease, revision situation, you are not able to identify the vessel by other landmarks. If you have a ground lamella picture, follow the ground lamella where it gets attachment to the skull base above, the anterior ethmoidal artery is few millimeters anterior to it. That's the most constant landmark one can relate for anterior ethmoidal artery. All other landmarks can be variable due to pneumatization, but this cannot change. Wherever the ground lamella goes up, I will show correlate surgically when we operate that how ground lamella is important and how you can relate with the anterior ethmoidal artery. Okay. Now as you go behind, what is there? See the complete opacification of this anterior and posterior group of cells. Now as you go behind in the posterior ethmoid, that is again a dramatic change in the picture as you go behind. See the orbit is becoming smaller, the maxillary sinus as you go behind becoming more and more oval, and the cells are much bigger than the anterior ethmoidal group of cells. See, this is important. Posterior ethmoid anatomy is most important to understand surgically, because this is the region which if you are disoriented, you are lost. If you accidentally enter into the sphenoid, it can lead to a disaster, because there are lots of critical neurovascular structures running in the walls of the sphenoid sinus. Hello?
Yes.
Now we are in the posterior ethmoidal roof and you see how thick it is. And now the which part of the turbinate goes to the roof? That is superior turbinate. And that's an important anatomy, superior turbinate surgically, to identify the sphenoid ostium, which opens in the recess, which is bounded laterally by the superior turbinate and medially by the nasal septum, the posterior most part of the nasal septum. So now the important thing which we need to make out here on CT on that basis surgically, that the transition from the posterior ethmoid to the sphenoid sinus, because the posterior ethmoidectomy is the most important part of the surgery in terms of complications. If we are disoriented and accidentally enter into the sphenoid, it can be a disaster. So we need to know exactly how the posterior ethmoids are transitioning into the sphenoid cavity. See, that's the posterior ethmoidal roof. Can you see?
Yes.
And the roof of the posterior ethmoid formed by the frontal bone.
Okay.
You see from one pterion to another pterion. Can you see this?
Yes.
As long as the roof is formed by the frontal bone, it is posterior ethmoidal roof. As simple as that. Behind is going to be the sphenoid sinus, and the roof of the sphenoid is formed by the lesser wing of sphenoid. Can you see here?
Yes.
So that's the sphenoid bone which form the roof of the sphenoid. See here in the previous section, that is posterior ethmoidal cavity, and here you see the nasal septum right from the top to bottom.
Yes.
Now as you go behind, see the beginning of the sphenoid,
Yes.
the lesser wing coming into the picture, that's the orbital apex, and see the level of the nasal septum, what is happening. The broadening in the center, that signifies the level of the rostrum of the sphenoid. Can you make out this? Now as you move behind, we are right in the sphenoid sinus now. So now we have the sphenoid sinus, that is the rostrum, and that is the posterior most part of the nasal septum, you can say. And we have two unequal sphenoid sinuses which are always like that, and this septum has to be very clearly appreciated and respected during surgery. Here fortunately we have a septum in the midline. Sometimes it goes eccentric, it may go to the see the level of the optic now, that's the impression. If you go behind and below, that's the impression goes to the carotid artery in the lateral wall, and that's the lesser wing of the sphenoid, which leads to this kind of a the process, the optic strut from the lesser wing to the body of the sphenoid. That's the optic strut, and sometimes it is over pneumatized to give a good opticocarotid recess, the lateral one here. So we have the optic nerve impression, the carotid impression looking prominent but very well covered by the bone. Sphenoid has hardly any disease, though it has the mucosa on the opposite side, and that is all sinusitis. So role of sinus surgery in such case, you know why we are operating this case. This is not infective disease, this is inflammatory disease which is governed by variety of cytokines. If you go to the pathophysiology, and all these cytokines, if anything works on them, is the steroid. This is eosinophilic disease governed by importantly interleukin 5, which is an important eosinophilic ecotoxin factor, and anything which works on this cascade is steroid. Now in such a patient, you give oral steroid, they do very well, but how long we can continue with oral steroid? They have their own adverse effects. So we have to have some strategy by means of which we can avoid the need of oral steroids in the future. So the goal of sinus surgery here to me in this case is to remove this inflammatory load completely, and at the same time this sinus mucosa, which is actually the disease part, will be exposed to the topical steroid if we deliver by various methods. So in the future, when the inflammatory load is taken care of and give access to the topical steroid to go inside the sinus mucosa, our purpose will be fulfilled by treating him on the basis of topical steroids in the future. So the need of the oral steroid is much less and avoided to the significant level. That's the goal of the surgery in this case. There are some important, you see in the posterior part of the sphenoid here. Can you see here?
Yes.
There are some important foramina. See, this is, the sphenoid is, this pneumatization is extending laterally. Where? There was a pterygoid process. At the expense of the pterygoid bone, when this pneumatization extends, there is the lateral recess. And you see when there is lateral recess, you see on either side two foramina. One is, the lateral one is foramen rotundum leading to the V2, and this one is the Vedian canal housing the Vedian nerve as well as the vessel. And now this is the nasopharynx proper. So having this case, was a diagnosed case of CRS, had multiple medical treatments. Our goal is to do a comprehensive, we call it as a full house sinus surgery, in this case bilaterally, and then we'll follow with the topical steroids, and then we do post-operatively certain workup in particular group of patients. Up to 10% of the patients are resistant because of several reasons, sometimes the severe vitamin D deficiency, sometimes aspirin sensitivity, and we need to take care of all these aspects in the post-operative period. Even the allergy can complicate the situation. So it's like a syndrome. We need to take care of all the aspects to optimize our outcome. Okay?
How old is the CT scan?
This CT was done on the 6th of last month.
What is the age of the patient?
Age is 32, what I was told, and the CT has written 31 years.
1 month. Any steroids given in between after the CT?
Any?
The steroid oral?
Yes, what I was told that she was given before the surgery some course of oral steroids and nasal saline irrigations.
How do you prepare these patients before surgery?
Yes, very important. That's very important and valid question. See, why we need preparation? The question, why does this question arise? Preparation, we need to have a good surgical field, the field with a minimal, what happened? Yeah, the surgical field should be like that which gives minimum bleeding in that region, so that we can identify the landmarks properly. This is a surgery of landmarks. Whatever available landmarks we have seen on CT scan, we have to further develop more landmarks as we go behind to prevent complications. So in order to identify the landmarks, there should be a proper good surgical field with minimal bleeding. And that to achieve that surgical field, we need to prepare the patient. Since this is inflammatory disease, the ongoing inflammation leads to vasodilatation, mucosal edema, inflammation, even the secondary infection, and all these contribute to more bleeding during sinus surgery. So the policy to reduce the bleeding is something you have to attack from various aspects. Preoperative is very important, like you asked, the preparation. We prepare such patients, polypoidal patients, with a course of steroids. Antibiotics have no role, I tell you. It's been proven in the literature. Yes, non-polypoidal sinusitis, where the secondary infection is more, antibiotics do have role. But in this polypoidal sinusitis, antibiotics, very peculiar part is antibiotics have no role at all. So steroid and nasal saline irrigation to bring the mucosa towards the normal side so that it bleeds less.
Duration of the treatment for a week?
Yeah, a week or so. Roughly, it depends. See, it's being very practical. It cannot be possible in all cases because sometimes you have to schedule surgery according to the patient's convenience as well. Like the patient from far off, from 1,000 kilometers, yes, you have scheduled after 10 days, 7 days, 14 days, it varies. But you must prepare anyway. Now the next part of the preparation comes is intraoperative. Intraoperative preparation is very important. Let me Wash up and I'll get back to you in 2 minutes, then we'll discuss.
Any role of antihistamines?
No. Big no. N-O, no. Antihistamines have no role in entire CRS management. This should be very, very clear, and unfortunately we see in prescriptions many a times antihistamines in the management of CRS. So, what does antihistamine do? Antihistamine blocks the histamine receptor to prevent the binding of histamine to the histamine receptor. And that is the end part of the allergic cascade. When the histamine is released, when the mast cells are degranulated, histamine is released, and then finally it binds to the histamine receptor, and the antihistamine block that. So in CRS cascade, antihistamines have no role at all. To be very clear. Any other questions, sir? Hello?
Yes, yes. Any question from the audience?
I request you to be generous in interaction for the benefit of everyone, to share your experience or anything you want me to show or do or discuss. So I'll be with you in 2 minutes. And what we can do simply to elevate the head of the patient by say 15 degree or so, and we call it as a reverse Trendelenburg position. There are a variety of studies done on raising the head by 5 degree, 10 degree, 15 degree, 20 degree. This picture.
This patient is under local anesthesia?
General. We always do under general anesthesia.
What is the
Lights on? Lights on. No.
Light.
Somebody lights on? No, not this.
what is the BP you try to maintain during the surgery?
Yes. Yes, that's what I am coming to, sir. That is one of the aspects. ओए क्या scope खराब है यार? Scope is not clear. What is there? Can you? Sure. Do we have another scope? No, dry gauze. Do we have another scope? Yeah, that's what I'm removing. Fogging. Can you change to the endoscopic picture, sir? This picture is not clear, boss. No. Do we have another scope? We are just waiting for the camera to be changed. Overall cardiac output. So in order to reduce the cardiac output, we always request his initiative of the world skull-based courses, the upcoming courses, which never happened before, is something going to revolutionize the skull-based teaching in our country. The group of people from the World Neurosurgical Society are coming and doing 3 5-day courses every year. It's amazing. This will open up the gateway of skull-based teaching, and that's amazing, and I'm happy to register myself as a participant in that. I'm so grateful to Sampath for considering, because the moment he announced his courses, in 3 days all seats were booked. No place.
Thank you for your kind words. It's a pleasure and honor for me to have you in our course. So, always a privilege to
No, boss, it's a privilege. I'm looking forward to that opportunity to learn from you. And those 5 days teaching, believe me, will bring out lots of queries, which you have to, will bombard you lots of queries, because you have been doing this day in and out with lots of experience. That's sure. Same here, dear. Thank you. So what happened to the camera? It's coming. So some more wait, as we are going to have another camera. Yes, this camera head has some internal fogging, haziness, which you can see the picture. We can't go ahead with this picture. So we were talking about the surgical field. So now, if you go to the landmark publication in otolaryngology head neck surgery from Seoul, done on 600 something patients, on this particular subject, the role of capillary bleed as a contribution in the sinus surgery. The most of the bleeding in the sinus surgery is attributed to the capillaries, and the best way to control is to reduce the cardiac output, which can simply be achieved by means of reducing the heart rate. So you keep the heart rate around 60, you'll get the best field irrespective of the blood pressure. You can operate in normotensive conditions without the need of hypotensive anesthesia, which can be sometimes problematic, particularly in the elderly patients. Now, to address this capillary bleeding, another strategy people would do earlier, which we have stopped for many years now, is to infiltrate the areas of the vascular confluences, like various points in the region of the sphenopalatine anterior ethmoid region. People would infiltrate. We have stopped that practice, having known that lots of complications which have been described even in the literature now attributed to the infiltration. If adrenaline happens to enter the systemic circulation, you can imagine what can happen in a labile patient who is already cardiovascular labile patient, particularly elderly patients, and lots of complications, even the mortality is been reported now. So this we have stopped for many years now, and exclusively, yes?
Sir, your voice is echoing a bit in the hall, so the mic can be adjusted a bit, the distance.
Can you इसको दूर करना माइक को थोड़ा दूर कर, इको हो रहा है. Yes sir.
There are two more cameras there.
Yes yes.
Ask them to check it and
Yeah. They are bringing.
doesn't matter if you take about 10 minutes extra.
No, it's already here. We are just changing.
Large audience here waiting to see your surgery.
Oh, thank
Take
you.
your sweet time.
Thanks for infiltrated and got a good surgical field. And this patient as well, you will see the field what we are having. I will show you with this topical preparation, and see what I am using for topical preparation. Another thing, yes sir.
The picture is very good.
Yes, but still it will improve as I am waiting for the white balance to come. Yeah, they are still loading.
Take
White,
your time.
yes. Now the white balance is left, and that will certainly improve the picture like anything. And this camera is fantastic.
Yes, the picture is better. This is a very good picture.
Yeah.
So what solution you are talking?
Are you doing white balance from there? Use at the end of the surgery in packing in the ethmoidal cavities. So there will be practically no added cost. And believe me, this is so atraumatic. Can you see this?
Yes.
You can push them into narrow recesses. It opens up, it swells up, opens up the cavity, opens up the spaces, and absolutely atraumatic to the mucosa. This is one thing which we have been practicing. And second thing, for the mucosa or for the surgical field, the saline irrigation is very important. Intermittent saline irrigation throughout the surgery, 50 cc syringe. So, to improve the surgical field, and there are lots of studies done on it about the solution which can be the best one, the normal saline, ringer lactate, isotonic saline, hypertonic saline. And recently, it's been again proven that the best solution is the ringer lactate, which is the most physiological to the mucosa, as it contains additionally the potassium and the lactates, as compared to normal saline, which is most physiological to this mucosa. We have to respect the mucosa. See, this is functional endoscopic sinus surgery, where we are supposed to preserve the function of the mucosa, which is going to be served by the mucosa only. If you remove the mucosa, if you damage the mucosa, then it cannot be FESS, then it will be mess. So we have to preserve everything, every bit of mucosa during surgery, as mucosa is not the culprit, it is the inflammation which is the culprit. And as the name looks like sinusitis, infective disease, everyone, this is not infective disease, this is inflammatory disease. Infection can just be a disease modifier, that's it. It cannot be the original pathology. Now, what we are seeing through this cavity, how the cavity is looking like after the decongestion?
Beautiful. Very nice image.
Yeah, give me the cottles. So what you see on the right side is the nasal septum with a little bit of the deviation, and see the camera, you can see the dense capillaries all over. And what you see in the lateral wall, this is the inferior turbinate, a very important anatomy, as you go behind in the nasal cavity, what you see behind is the nasopharynx, the eustachian tube in the lateral wall of the nasopharynx. Can you see there?
Yes.
And this is the nasopharynx, the posterior wall, the superior wall, the roof, which is forming the floor of the sphenoid sinus. And this is behind this recess, which is going behind this torus of the eustachian tube, going towards the parapharyngeal carotid artery. That recess is the extension of the nasopharyngeal cavity. We call it as a fossa of Rosenmuller. This is nasopharyngeal, the eustachian tube orifice, and this flat surface anterior to it belongs to the medial pterygoid plate. Now this is the inferior turbinate, is a different bone. This middle turbinate is a different bone, that's part of the ethmoid complex. And this middle turbinate, as I said during radiology, is one of the most important landmarks during sinus surgery to protect the surgeons from various problems. And it has three parts. What you see up front is the first part lying in the sagittal plane. Can you see this? And this has this anterior attachment onto the beak or the frontonasal process over here. And posteriorly, it goes high up. I'll show exactly where it takes attachment to the cribriform as we dissect further. It goes high up to the cribriform at the junction of medial and lateral lamella. Now, so coming here, this region is the most important region for the sinus surgeon. That is the osteomeatal region. And why it is most important? Because all these, the narrow, the crevices and the compartments in this region of the anterior ethmoidal complex leads to the problem in the dependent sinuses. See here, if you see the prominences and depression in the lateral nasal wall, can you see? The first prominence here, what is that? That belongs to the nasolacrimal system. Can you see? That's the nasolacrimal system, which goes up, broadens to form the beak. It is formed partly by the frontonasal process and partly by this inferior turbinate process and the lacrimal bone. Behind that, there is another process. Can you see that? Can you see this with this polypoidal change? What is that? That's the uncinate process. Sometimes, see this polyps, and sometimes more massive polyps can obliterate this anatomy and makes your identification of the uncinate very, very difficult. So, the easiest way to identify the uncinate is the mobility. The only mobile structure in the lateral nasal wall, in the entire lateral nasal wall, is this uncinate process. And this is very, very important structure for the surgeon. Even the smallest problem or smallest mistake can lead to a disaster. See this uncinate? This is just the polyps arising from it. This uncinate has a vertical part and then it has a horizontal part. Going to the varying distance behind, sometimes it gets lost in the turbinate itself, the inferior turbinate, and many times it goes behind even to the perpendicular plate of the palatine bone. Can you see this? Yes. This anatomy, what is there in the lateral wall? That's the perpendicular plate of the palatine bone. That's very important bone. Not much of importance in the sinus, but in the skull base surgery, when you do ventral skull base, it has relationship with lots of neurovascular structures which are very, very important in skull base surgery. So this uncinate, the upper part is very important. It practically, this is one thing which has a major role in determination of the frontal sinus outflow. And majority of the time, fortunately for the surgeons, majority of the time it goes up, fuses with the medial wall of the Aganegi, and then from there it goes along the wall of the Aganegi towards the lamina papracia, inserts laterally. And what happens then? Insert laterally and the frontal sinus outflow remains medial to it. But it's not always. But in the recent studies, the incidence of this lateral insertion of the uncinate is almost 98%. Less than 2% situation we may find uncinate going somewhere else. It may be pushed laterally or medially to get attachment on the middle turbinate, or it may be pushed high up to get attachment right on the skull base, but that's so uncommon. You don't need to get terrified all the time with this, but yes, you need to keep in mind, and a very good coronal section, you can make out the entire course of the uncinate. You need to have a 0.625 mm sections. So, This is the uncinate, and this is very important as the first part of the sinus surgery is uncinectomy. And if it is not carried out properly, it can be a source of recurrent problems. We have seen patients where the incomplete uncinate removal, incomplete care of these fontanelles leading to the recirculation and the persistent problems, persistent symptoms. So this is uncinate, and the structure behind the uncinate. Can you see this globular structure? That's the most prominent anterethmoidal cell. That's the bulla ethmoidalis. And this bulla and the uncinate, this is a cleft-like structure in between. This is hiatus semilunaris inferioris. That's a two-dimensional structure. And if we go into it laterally, see here, laterally it leads to a three-dimensional space. I will open up when I open the uncinate. That three-dimensional space is infundibulum, into which the maxillary sinus ostium per se opens. So whenever you see any opening in the lateral nasal wall in an unoperated situation, it cannot be an ostium which is a three-dimensional structure. What you see this punched out, see this punched out defect? What is this? That's the medial wall of the maxilla and has a defect, bony defect with only, see the mucosa on either side in the surrounding. Two layers of mucosa, one the inside mucosa and one the nasal mucosa on either side, and forming this. And this, if it is posterior to the uncinate, it is posterior fontanelle, anterior to it is anterior fontanelle. And the fontanelle, whenever they are, the importance lies in the fact that you need to communicate with the natural ostium. As otherwise, if the phenomena of recirculation starts, then it will defeat your purpose. Besides this, what another structure which is important to us? See, this was bulla ethmoidalis. See, medial to the. Are you getting? Don't change the endoscopic picture, please. Tell them. Okay. Now, looking at the bulla here. See this bulla ethmoidalis? This is a turbinate. And what is this cleft between these two? Is hiatus semilunaris superioris, and if you follow it behind the bulla, that is a retrobullar recess. This very important to understand and see this, how this retrobullar recess is developed in the patient. Many a time the bulla is big and even gets fused to the middle turbinate, and sometimes the bulla is atrophic, very small, and you will find the bulla, the space above the bulla as a suprabullar space, which is normally you will not find as the bulla goes high up to the skull base. Can you see this? This bulla goes high up to the skull base, and that is one of the most important landmarks we utilize in surgery. As if the bulla goes to the skull base, again this is over 95% of the situation that bulla goes high up and takes attachment to the skull base. Less than 5% situation, there is a space above the bulla, and then you have to be careful. Then you have to stay careful, because in that space the skull base is exposed above, and the vessel which goes along the skull base, the anterethmoidal artery, may be right in front of your instrumentation. So we have to be careful in that situation not to jeopardize the anterethmoidal artery accidentally and then further complications. So again, finally, what I am using? The same marrow cell soaked in saline and adrenaline. This combination is different according to the patient. For a young patient, I won't mind using even a pure adrenaline, but only topically. For elderly, I will dilute to 1:4. Though it is, those topical is very, very safe. You see the number of articles published. Topical itself prevents its further absorption, and it is very, very safe of whatever concentration you use. But in elderly, we stay on the safer side and use a more diluted one, even for the topical use. We never even ask for the hypotensive anesthesia in elderly patient. You know, earlier, the studies were done on this hypotensive anesthesia, and finally, all the expert committees have now declared that the hypotensive anesthesia has hardly any role. Rather, it can be detrimental in a labile patients. See, it has been studied, if the mean blood pressure goes below 60, it can affect even the middle cerebral artery flow. It's been proven. So we have to stay very, very safe. We can't take a chance of such graded complications in such a benign disease. See this, what I have done? Just debrided the polyps. This Microdebrider is an amazing tool, is one of the most important tools in the sinus surgery armamentarium. But the most important tool has to be used very, very safely, very, very meticulously, otherwise it can be most detrimental. If you go accidentally into critical areas and run the debrider, like you go in the orbit and run it, you can debride the entire orbit in less than 2 minutes. So be careful. The most important principle of the Microdebrider is to keep the cutting edges in view. Can you see this?
Yes.
So that when you use, you know what exactly you are cutting. This is very important. See, in sinus surgery, as I said, respect to the mucosa is most important aspect to get the best outcome of the mucociliary function. So instrumentation, the way you introduce the instrument is equally important. See, for the junior colleagues here, this is very, very important aspect. If I am using the instrument in the right nasal cavity, can you see? Hello?
Yes.
In the right nasal cavity, I am fixing my endoscope, taking the help of the ELA to keep my endoscope stable and in place. And see, my endoscope is coming from the lateral side. And once you take the endoscope at the opening, bring the instrument in, that is along the medial wall, that is septum. So the strategy should be all the time. See this? Bring your endoscope at the opening, introduce your instrument and then go together. See this? Go together. So whatever you do under vision, bring them out under vision so you don't traumatize the opposing surfaces. It's very common to traumatize them and then get lots of crusting in the post-op. Crusting, believe me, is a negative impact like anything. More the crusting, more are the chances of the bone getting exposed, secondary infection, osteitis, and then your FESS ultimately turns into mess. So be careful about the instrumentation, how to introduce even is very, very important. Now, coming to the next part. As I told you, the first part of the surgery is uncinectomy. Can you see this complete uncinate process? The upper vertical part, I debrided the polyps from it, and the lower horizontal part, and that's the posterior fontanelle. Now, how to address this uncinate? See this uncinate? There are many, many ways to remove it. Traditionally, when Messer Klinger and the Stamberger started, and even I have done several times earlier, we used to take the sickle knife along the lateral attachment of the uncinate and bring it sometimes even toto in one piece, in toto. But what we have realized many a times, you have to be very careful, particularly at the scans before, that how close you are to the orbit, how close your uncinate to the orbit. Sometimes the maxillary sinus is not very pneumatized and your uncinate is very close to the orbit. In that situation, if you use the sickle over here, you can get an accidental entry into the orbit, that too at the beginning. Imagine if you get an accidental opening into the orbit, that too at the beginning, what's the temperament of the surgeon going to be? So be careful even at the first step that handle the uncinate very, very carefully. It is a very important structure, and what we have been using is to address this problem is a reverse biting forceps. Now see what I am doing. That's a reverse biting forceps. Can you see? Open up. Introduce, open up. Can you see? At the junction of the vertical and horizontal part. Introduce fully and turn it little down. That's very important. See what is there anteriorly, the nasolacrimal system. And as you go down, it comes closer. So it goes away. As you go up, it comes closer. So if you turn it down, you are literally more away from the nasolacrimal system, which is the most important thing at stake for damage during this stop. It is not cutting through. Give me another. You have another backbiting? This is not cutting through, boss. Can you see this?
Yes.
Just introduce, bite through, further introduce, advance until you come across a hard bone. Can you see that?
Yes.
So that's how, what is that hard bone? That's the concern in this use of backbiter at this step. If you are not careful, that hard bone belongs to the frontal process of maxilla, which is forming one of the walls of nasolacrimal duct. So if you come across a hard structure, don't bite through, wait, retract it, again try to bite through until it reaches the hard bone, so as not to bite through the hard bone and prevent this complication. Now, what we have achieved by this? We have made this opening in the uncinate. Can you see this? This is the upper part, vertical, this is the horizontal, this is the bony plate of the horizontal uncinate. Having made this, what is this? Can you see? That is this entire region. See this three-dimensional structure, this entire one. That is infundibulum. This was the hiatus, semilunaris. This is opening to this three-dimensional structure, that is infundibulum angle. Here 4011. So that is infundibulum, into which this maxillary sinus ostium opens. Can you see that?
Yes.
So that is the horizontal part of the uncinate, curved section, my dear, and that is the natural ostium of maxillary sinus. If you see carefully, just keep your, see this, what I am doing, keep your ball probe vertical and fracture gently this horizontal portion. I can remove this horizontal portion separately. I can debride this mucosa. Anyway, whatever way you want to remove, you can, but don't damage the mucosa unnecessarily. Sometimes people make the flap out of it. To me, it actually, we have done several times, but it's not needed. See, this maxillary sinus is one sinus which, if opened properly, taken care of the uncinate with complete removal, taken care of the accessory ostia, it hardly bothers in terms of opening. क्या दिया तूने? What is this? अरे यार, no, कौन सी ब्लेड दे दी भाई? Give me the 40. गौरव. Unlock करके उसको. गौरव, you help him now. Okay, sir. So now what I am using simply is a red 40 microdebrider blade. Can you see? And I can debride along with this horizontal portion of the uncinate, that's a thin plate of bone, and create a middle meatal antrostomy. Can you see that? There is a 40. 40 is the most useful blade, I tell you, during the sinus surgery. See this? And I am joining this ostium, the middle meatal antrostomy, to the to the accessory ostium. See that? This is very well mucosal lines, and this kind of opening, after having taken care of this 45, taken care of the uncinate removal and the accessory ostia, it really bothers. You may find many a times post-operatively, see the follow-ups, with a big maxillary sinus opening and yet the polyp coming out of it. That's not due to the middle meatal antrostomy problem. That is due to the inflammatory disease which is not being addressed post-operatively by the topical steroid. So antrostomy per se or middle meatal antrostomy rarely gives problem. The problem we need to understand the pathophysiology of this disease. Now see the upper part of the uncinate. See, this is the middle meatal antrostomy what I have designed. Can you see? Hello?
Yes, very well.
Yes. So now there are people, there is always a debate. Many times I have been asked that what should be the optimum size. See, it's again tailor-made. So what kind of disease you are addressing, it depends upon. Having a massive mucosal disease, eosinophilic disease, I will always create a bigger or a mega meatal enterostomy. In a minimal disease, wherein the long-term steroid irrigation or long-term follow-up is not warranted, you are not supposed to create this bigger enterostomy. Bigger enterostomy is required when you have to deliver large amounts of topical steroid in the sinuses for the mucosal disease, eosinophilic disease. If you want to make it bigger, I can easily flush this up to the posterior wall. Can you see here? Yes. Then it would be, I would call it as a type 2 if I flush behind. If I have a massive fungal disease where I need long-term surveillance, massive eosinophilic products, then I would flush it with the floor at the expense of this part of the inferior turbinate, and we term it as a type 3 middle meatal enterostomy. Type 4 is, you can say, medial maxillectomy, which is rarely required in this massive or in this mucosal disease. Yes, many times we have done for the multiple revision. We have cases operated 10 times, 15 times, even 20 times. Now see, this is the upper part of the uncinate. I told you, the goal in sinus surgery is to do a complete comprehensive full house sinus surgery. At the same time, give exposure or the access of the topical steroids everywhere. But equally important is prevention of complications. Now this upper part of the uncinate, what I am trying to achieve, what I am trying to say, the simplest way is go behind. I can remove it anyway. I can remove with a microdebrider, I can remove with a through biting. For this movement, I always advocate the junior colleagues to get adapted to go behind the structure and fracture it away from the skull base towards the surgeon. See this? Go up and fracture towards you anteriorly. That is the safest movement. You can't damage anything behind. Can you see this?
Yes, sir.
This entire uncinate process is fractured. So simple. That is the best way, and this movement will follow everywhere when you go behind to remove anything. Best way is go behind and fracture it anteriorly. Now I am trying to remove this bony plate, though I can debride it. There is a very thin plate, but let's remove it. See this? Debride. Wash karta. No. 40. Why you change? Don't change, please. So here I am just endlessly change the blade. I am getting the same blade, the red 40. I tell you this red 40 when I am using, when red 60, when straight, when 120, and when the so-called adenoid blade. It is very important blade, the skull-based blade in sinus surgery. Now, see this? Hey boss, this blade is clogged. Sandeep. Why? Either the blade is clogged or suction blocked. See, for the sinus surgery, for this microdebrider to function optimum, it is must. If you are spending 10 lakhs in microdebrider, spend 50,000 for a 1 horsepower section, which will ultimately improve the life of the blade by 3 times.
You said 1 horsepower.
1 horsepower is the ideal one for this microdebrider, because this entire thing, the optimum functioning is dependent upon the suction backup. Otherwise, your blade will keep rotating to cut the tissue, and if it is not suctioning from behind, the blade will be ruined, and the ultimate burden falls on the motor. This IPC system from Medtronic is most amazing as far as the microdebriders are concerned. See now, under vision. Now what I am trying to show you here, one of the most important part of the sinus surgery in the beginning, this lateral, blade. Are you using the old blade or what? It's not functioning. Clogged. Boss, put a wire. See how important the suction is. Everywhere. Same problem. The wash.
वो देखो
हाँ जी,
एक बार
जब मौका लगे
सक्सेस से नहीं जाएगी
जब मौका लगे वॉश कर, उधर ध्यान दे. Hello?
Yes, sir.
Yeah, I am getting the blade to get free. And meantime, whenever you get time, just keep optimizing your field. How is the field there?
Yes, good, very good.
See now, we didn't infiltrate at all. And see the kind of field we are having. Just topical preparation and the heart rate, nothing else is required. This is the time, the era where you are not supposed to operate in too much of bleeding going on. It has to be ultra dry field, and what you can do in between after every step is mopping with the marrow cell. See the same marrow cell piece again soak in the same solution and repeatedly you can use throughout the surgery. See that? Still not open? Hey, who is from Medtronic here? बस ग्लव्स पहन के आ जाओ उधर ब्लेड खोलने के लिए. See now, introduce your blade every time with the navigated by the telescope. Now this step is very important here laterally. What I am trying to say, my lateral limit of this corridor is going to be defined at very early part of the surgery at this stage. See this. What you see laterally? What do you see laterally here? Hello?
Yes, this is I think
That's the lamina papracia. Now this is the upper part. See here. Remove this uncinate completely up to the axilla. This cell and the cell we are opening up here. See this? At this point, can you see this? What is that? Agar Neji. This anterior wall of the bulla has been removed here. Can you see that? Now, the biggest question here, I am still using a 0 degree. I have not changed the telescope yet. See that? What you see here, what we have done so far. We removed the uncinate and here the bulla anterior wall was prominent. You see? Can you see this is a part of the anterior wall is going to go high up to the skull base. Now this middle turbinate is all the way your lateral limit, medial limit. And see here carefully, that's the lamina papracia. That is going to be your medial limit. So while removing this upper part of the uncinate, this is the time to define your corridor. That all the way during this full house sinus surgery, these are our two important limits. The medial as well as medial as well as lateral limit. Can you see? The medial limit defined by the turbinate and the lateral limit defined by the lamina. This is going to be our corridor, and if we respect the limits, we can certainly avoid these avoidable complications. So every time, wash. Just mop with the marrow cell, wash with the saline or the ringer lactate, and optimize your field. See now, every time we have to develop a new landmark to go behind to save ourselves from complications. See the field?
yes, good.
Now at this time, I'll change to 70 degree for the reasons I'll tell you. We all know the frontal sinus is considered most challenging for various reasons. And the biggest reason is the fear of complications. Okay? The reason being the frontal sinus is so strategically located at an angle high up. And to address that, you need angle telescope like 70 degree telescope, which gives you a sort of optical distortion. So you have to use angle instrument. You are looking in front, but your telescope takes you 70 degree away. Can you see this? This is the 70 degree now. I changed to 70 degree here for the reasons I'll tell you. This I call it as a man of the match telescope for sinus surgery, as it gives you opportunity to address this most difficult aspect of the sinus surgery in a simplest manner. The frontal sinus work, frontal sinus work you can address in a very, very simplified manner. See this? Now, why I changed to 70 degree? The reason being the fear of complications in the frontal sinus surgery. And what are those fears? Basically 3 fears. And I will try my level best to shatter your all the fears down today by taking into consideration certain landmarks and this man of the match thinks that is 70 degree. See now, what are 3 fears? Number 1, if you go medially, your frontal sinus ostium is very close to the skull base. So there is always a fear if you go medially that you can hit the skull base and can get even a CSF leak. Okay? Take your landmark all the way. This is middle turbinate. Can you see? I can see it high up all the way. How it is possible? 70 degree.
Can you use 45 instead?
Pardon?
Can you use 45 instead?
You can, but the view you get with the 70 is unparalleled. Amazing that the 45 cannot compete. So if you talk of the best is 75. 70, okay? Now, so medial limit is your turbinate and that is to, if you consider it as a medial landmark, if you don't cross it, you will practically will not hit the skull base, okay? And this is possible by viewing this entire length of the middle turbinate high up to the skull base, all the time. Second is your lateral fear of damaging the orbit. See the medial wall of the orbit? See this, the big organage. See this medial wall of the orbit. As long as you keep this medial wall in view and don't cross it, you can't enter the orbit, you can't give any complications further. And third is the fear of anterior ethmoidal artery. I tell you how you can easily address that. See this is where we are directing. This is the bulla, the anterior face of the bulla which is going up towards the skull base. And this we are directing to the level of the axilla, high up. Anterior ethmoidal artery, this skull base is going down behind. Anterior ethmoidal artery is at the posterior most part of the anterior ethmoidal roof, I told you during radiology. Here we have not reached even the frontal sinus. Frontal sinus, 1 centimeter behind the frontal sinus ostium will be the beginning of the anterior ethmoidal roof, and behind in the end of the anterior ethmoidal roof will be the posterior ethmoidal artery. Okay? Yes. So if you are working in this trajectory anteriorly, your anterior ethmoidal artery practically you can say is miles away. And what additionally is protecting that as a safeguard to us, that is protecting from surgeons to the anterior ethmoidal artery, is this bulla ethmoidalis. See this? Yes. This superior extension of the bulla to the skull base. See this? Yes. This anterior face, this goes to the skull base, and wherever it goes to the skull base, the anterior ethmoidal artery runs behind that attachment. So as long as you keep the bulla intact, what happens? Your anterior ethmoidal artery is automatically protected. You get my point?
Yes.
So remove your fears, understand this trajectory with the 70 degree where we are aiming and where can the anterior ethmoidal artery be. So that's the fear factor that terrifies the surgeon. With 70 focusing anteriorly and see the field, you should be able to see each and everything. Now what we are seeing in front of us, this is the turbinate, my medial limit, this is the orbit, my lateral limit, this is my axilla, and this is my anterior face of the bulla. And this is what? This is what? Organage. Now I told you the superior part of the uncinate gets fused with organage and go laterally to the, see where this is going? Laterally towards the lamella. Can you see? If I pass this instrument, simple ball probe, between this lamella and the middle turbinate, which is ultimately the medial limit. See this?
Yes.
I am fracturing this lamina. How? See, my direction of my instrument is laterally. Can you see my instrument behind this lamella?
Yes.
See the instrument behind? So go behind the instrument, direct it laterally. See, laterally, gently and anteriorly. Simplest way, why I am able to see everything so clear? It's all because of this man of the match 70 degree. See this? Direct your instrument laterally and fracture this lamella anteriorly and laterally, and what you open up behind, that is the frontal sinus outflow. Can you see there?
Yes.
I will show you. So what I am trying to show is the safety concern, so that you don't hit the skull base behind and medially. Yes. See that? Yes. Give me the wash. I'll show you very, very clear, so that no doubt remains in the future to address and making it unnecessarily complex. See? See where I am going? See my territory, my medial terminate 60. Medial terminate all the way is in our view. Can you see? Let me change to a 60 degree red 60 blade. Hello?
Yes.
Now I am changing to my red 60 blade as I go high up. See this, how to use this blade along with the telescope. See that?
Yes.
Thus I am removing this redundant mucosa. See this redundant mucosa, respecting what? This turbinate. Can you see something? Hello?
Yes.
Now there are numbers of openings in this region, and everyone.
Can we see this artery?
No, not really. I told you we are working far anteriorly. You can't see anywhere close here the anterior ethmoidal artery. I have a safeguard to anterior ethmoidal artery. What is that safeguard? This bulla. That's why we never remove the bulla first and take the advantage of bulla and call it as an intact bulla technique, which one of our the legendary sinus surgeon, Dr. Dharamveer Sethi, would describe in details long back. See this? Now, as you open this, now the next thing to take into consideration here to simplify your aspect is the beak. Can you see this?
Yes.
I told you beak is a very important landmark during radiology, that it forms the floor of the frontal sinus, and the frontal sinus opens from behind. Remember? Hello?
Yes, yes.
So beak is one of the best landmarks for the frontal sinus. Now see, if you remember what were the cellularity in the frontal sinus region during radiology, if anybody. Number one, there was a type 3 kind of a cell.
Yes.
Okay?
Yes.
And there was a supra-orbital recess.
Right.
Now how do you differentiate? See now every opening here looks like frontal sinus. One can easily be mistaken with all these openings of the frontal sinus and come back happily. To differentiate the sinus from the cell is very, very important, and simply by your experience, cells are always thin-walled. Okay? Cellular septa are thin-walled, and the sinus is a thick-walled structure from behind. Okay?
Yes.
Now here, having known the radiology in mind, we have seen that the kind of cells we are going to have it. Sometimes you are further complicated by a presence of an intersinus septal cell. Now, how easily you can differentiate here? Number one, had there been an intersinus septal cell, it would have been the anterior-most cell over here and medially. See, in a coronal section CT scan, if you come from anterior to posterior, the first cellularity you see is a intersinus septal cell. Okay? That is the most anterior and a medial anatomy. Now what I am doing, I am least bothered about, looking at the frontal sinus from beginning. See, what happens, the temptation. Once you are in this region, just open the frontal first. Never. First define your limits. Can you see the beak? The cells along the beak should be flushed first. As you follow the beak, where the beak ends should be the frontal sinus. Okay? See, simple. This was the axilla. If you follow here, this is the beak, and where the beak ends should be the frontal. Now, how it is complicated by here? We had a type 3 kind of a cell, and now where the type 3 is, see this. That is this cellularity type 3 has pushed the frontal drainage medially. Can you see my? See my instrument? Where it is? See my instrument. It is behind the cell. See now? Right from the uncinate, I told you from beginning, the most important movement in sinus surgery is go behind and fracture anteriorly, if you remember. So what I did here, just went behind the septation and a gentle fracture on it anteriorly. Now let me clear this to show you where I was working. I have not removed the septation completely, just to orient you. Can you see something opening up? Hello?
Yes, because they are seeing
Now what I want to show you, the difference between the wall of a sinus and a wall of a septa, wall of a sinus and wall of a cell. See this. Make it very, very clear. So in difficulties, I will give you some tips so that you can always get over by yourself without any external in the situation when you are confused with so many structures in this region. Your supraorbital cell may confuse you by a frontal sinus. Supraorbital cell, out of all these pneumatization, is the most posterior structure. Intersinus cell is the most anterior structure. All these Kuhn type 1 through 2, 3, 4 cells are anterior to the frontal sinus opening and complicate the drainage from front. Suprabular or frontobular comes from behind and complicates from behind. Now, what I am trying to show here, see the difference between the cell and the septa. Cell and the sinus. See what is there medially? Is the frontal sinus itself. Can you see this? Dense wall. That's the look that you need to get used to. And that's a thin wall septation. See that? You will find in the sinus a lot of scallopings in the highly pneumatized sinuses. So here simply you can identify by means of 120 level. By means of badi wali ball, lambi ball, cell seeker, badi wali ball pro. Need to do here, we know this cell is complicating our frontal sinus outflow. See how the frontal sinus opening is narrowed. It is so small here, complicated by what? This cell coming from here. So what you need to do is go behind this cell and fracture it out. See this? You can easily fracture this cell. See that?
This is a type 3 cell which we have seen.
Yes, exactly. Now see, when I fracture this cell, my opening of the frontal sinus, can you see the scallopings inside? Can you see the dense wall? So what is all this? This was my type 3 cell which I have fractured. See the cell which I have fractured. So you need to understand simply that the anatomical orientation is very, very important, and that is guided by the radiology. I call this radiology, people call it as a road map. I call it as a Google map for sinus surgery. Radiology is like a Google map for sinus surgery. See, at our center, to everyone, all our junior colleagues, I always advocate to sit with the CT scan for half an hour minimum. Grab the anatomy of that particular patient, to the giraffe, anterior, posterior and lateral. Grab the anatomy three-dimensionally. There are so many things, every possible thing what the kind of patient you are going to have will be depicted on radiology. If you are not thorough on the radiology yourself, you cannot do a proper job in sinus surgery, and never ever rely on the radiologist. That's a big joke. If you see the radiology report of a sinusitis patient, they will report as a bilateral pansinusitis. See the cellular septa? This type 3 cell? Can you? Simple. So, what will radiologist say? The patient having mucosal thickening and the pus collection, edema, all this in all paranasal sinuses, bilateral, suggestive of bilateral pansinusitis. What does it mean to us? We know it. What we want is the anatomical details, the cellular details, which radiologists do not give because they are not, practically they are not very good at reading the paranasal sinus CT. During their training, they are more trained in the imaging of the brain, thorax and abdomen rather than the paranasal sinus. See that? Cell wall, give me a good.
What instrument do you use to remove these septa?
See, I have many instruments. Presently what I am using is a horizontal giraffe. Can you see this?
Yes.
See how simply you can open up the frontal sinus J-curate. So easily, and the blade I used, see here again I will show you, this is a very important blade. See this, the blade I am using is 120. By means of which, under vision, see this, you can walk well inside the sinus. Can you see? And that too under vision. No other blade will go under vision, it will make you blind if you try to use.
But is it safe to decide with the debrider inside the sinus?
Yes, as long, see, debrider advantage, the biggest advantage of the debrider is up and for safe, is it is mucosal preserving, it cuts sharp, it doesn't pull the mucosa.
Yeah.
If you are using under vision, there is nothing like it, but if you are blind and not using under vision, can be a disaster. J-curate. So now, I have widened the frontal sinus opening, see this? But still I am not happy. See this? See this cell further? I am using the J-curate here. Again, the movement is posterior to anterior. See this?
So this is the part of the angle?
Yes. See this now further? You can see the type 3 cell further. The internal part of the type 3 cell you can see better. Articulated rakhna. Gaurav? Articulated. See this?
Yes.
If I try to pull with the forceps, this mucosa will strip off. It will bring in continuity the other mucosa which I am not intended to remove. And see my 120 blade. It gives you the comfort of doing this work under vision.
Yes.
खोलना इसको, the section backup is poor. खोलना इसको, blade block हो गई. संदीप, सुन नहीं रहा क्या? Yes. See now, initially when we started, did you see the size of the frontal sinus?
Yes.
See, it is always a matter of debate. I call it unnecessary debate, that what should be the ideal size of the frontal sinus opening. That you cannot dictate. It depends upon the anatomy of that particular patient, how pneumatized it is. But how you relate it, that if you are doing a frontal sinus work in this era, which has the biggest, the biggest region for a revision surgery, is almost always a problem in the frontal sinus work because of incomplete work done in the frontal sinus because of fears. Now, so far we haven't seen the supraorbital cell. I told you it is behind. Okay? I will show when I go behind. We are working far anteriorly. Again to orient you, this is the level of the axilla.
Yeah.
Beak. Now see at this level, this is the thickest part, beak, you can't debride it. Medial limit is turbinate. Lateral limit is orbit. And if you stay along the beak, between the lateral and the medial limit, if you go along the beak, where will you go? In the sinus. So in the most difficult situation, this is one of the useful tips, believe me, is to take the reference of the beak for the frontal sinus. See this?
Yes.
I am further opening my the cell wall by means of this instrument. That's the long cell seeker See this? Reverse. You need a lot of instruments in the frontal sinus. Sometimes to widen it, to go inside, we use a articulated punch. Many times you may need a drilling or some sort of a limited draft, because you need a full access to work inside to get the cell out completely, or you flush the cell with the sinus. So the aeration and the mucociliary drainage is maintained. Reverse. So now what the blade I am going to use, I will tell you, we call it as a skull base blade. This is the so-called adenoid blade. It's a reverse cutting blade. Can you see this? Yes. But with the 70 degree, it becomes front facing. Can you see? Yes. Now see. Find all. See this? I am removing this septation which is lying along the. Oh, come on, endoscopic picture at this important point.
You can see that the cutting part is now sticking down.
Yes. See this?
Yes.
Now I'll show you clearly. What I am taking this septation along the floor of the frontal sinus, which no instrument otherwise will be directed to it. See this? And this under vision, this is the so-called adenoid blade, which we never advocate for adenoidectomy, as it defeats your first principle under vision. Because if you use a rear facing blade in adenoids, it may damage your structures behind. See now the final opening of the frontal sinus?
Very right, yes.
So these type 3, type 4 cells puts challenges to the surgeon, need little bit more expertise, more understanding, and some good instrumentation. See, there's a complete cell wall out. Recently we did a workshop in Trivandrum. I'm thankful to Dr. Sahil for the amazing cases he kept. And one of them was a type 4 cell. Now see the scallopings. Can you?
Yes, yes. Beautiful. Yeah.
So, if you don't do this kind of a frontal sinus work, the problems are imminent, and then that's why this sinus surgery is many a times got a bad name, that the sinus disease cannot be treated and you have to undergo surgery again and again. There are certain regions which are preventable. What we need to understand, two aspects. One is the pathophysiology. That's an inflammatory disease, requires steroids, irrigations. Second is the anatomy and a comprehensive work. Third factor which works for the surgeons is the fear. 120. The third is the fear. For the fear of damaging the critical structure, the surgeons won't go close to that area and do some sort of under job and ultimately end up with a problem. Now I will finish this frontal sinus part. Anybody, any questions regarding the frontal sinus, please?
I just want to ask, if you have a frontal sinus mucosa,
Yeah.
expanding supraorbital extension.
Yeah.
What is the approach?
Same. See, mucocele itself does half of the job of the surgeon. As it widens the space. What mucocele? Mucocele is a different disease, I tell you. See where I am working. Deep into the sinus.
Yes.
How come? With a 120 blade under vision. See this? Everywhere it is mucosalized. See this?
Yes.
See, mucocele is a pure surgical entity. It doesn't come in the category of CRS.
Yes.
It's a simple obstruction to the outflow. Okay? And mucocele, there is no medical treatment, nothing. You have to straight away go for surgery without any prior preparation or treatment. See now, that's the final picture of the frontal sinus, except one thing which I will look at it. What is there medially here? What is this? Whitish opening. I showed you a small osteoma.
Osteoma, yes.
During the radiology, that was a very small osteoma. We'll address it at the end. And this is a very important thing, though it is not symptomatic. Such a small osteoma is never symptomatic. And it is not giving any significant obstruction also to the frontal. Can you see this? We have done the entire job of the frontal sinus, widened so big. Yet we didn't bother about the anterior ethmoid artery anywhere. We didn't discuss about it. I told you practically we are miles away. So where is the anterior ethmoidal artery? Still we are quite away from it. See my bulla? Where the bulla is going? See this? High up, high up, high up on the skull base. See this? As long as you are anterior to the bulla, above it, just forget about the anterior ethmoidal artery fear.
So that forms the posterior wall of the frontal.
Pardon? Pardon?
It makes one of the boundaries of the posterior wall of the frontal side.
This bulla attachment?
Yes.
Yes. Sometimes it goes to that, sometimes it goes up to one cell behind. It's not always fixed. See now? That's the final picture of the frontal sinus, and the most important thing is the mucosal preservation. Now, what is the importance of mucosal preservation? See, in the recent classification published in the top class rhinology journal, I read the best one in the world, is the American Rhinology Society Journal, International Forum of Allergy and Rhinology. The most difficult frontal sinuses are the one where the scarring is by previous surgery. Scarring why? Because of the mucosal denudation is ultimately healing by the scar and the fibrosis. And those are the situations which are most difficult to treat. Okay? Believe me, those situations before you take up, you need to think twice before doing, explaining your patient, knowing your competence. Otherwise, it is going to give you the worst time, the scarring. If you don't touch the frontal sinus and you have to come back in the future for the frontal sinus work, that is a different. That will be like a primary situation. But having done that and not doing a complete job can be a problem. Reverse. Now, see this? Bulla? What we have done so far, that is middle meatal enterostomy, that's the frontal maxillary sinus. That's the medial wall of the orbit. That's the bulla. That's the frontal sinus. And this is what I am showing with is a 70 degree, that's the turbinate. See the turbinate? Respect. The only thing turbinate requires is a respect, nothing else. If you don't respect the turbinate, your life will be difficult and the patient's life also will be difficult. Now see again my skull base blade. See this? Reverse, the so-called adenoid. What I am doing now? See, the skull base direction is going behind. Okay? I am working anteriorly. See this? To open up this upper part of the bulla. See this? Simply it is the best way so that you don't damage the skull base. See, my direction of debridement is away from the skull base towards me. Can you see this?
Yes.
And see this, what I am opening. See this? I am opening the upper part of the bulla to show you something. See this? Now, can you see what is this cell going laterally above the orbit? Hello?
Yes.
What is this cell? See this going up high? That is supraorbital. Now, what I told you during radiology, this is the most posterior cellularity. Okay? Now see, where the frontal sinus was anteriorly and where the supraorbital, where the frontal sinus is far anteriorly and where the supraorbital cell is far behind. Sometimes the supraorbital cell, many a times we have seen, is actually the bigger than the frontal sinus itself, and then anybody can be easily mistaken. Yes, 60. So you have to be careful. The only thing which prevents you from complication is the radiology. Again and again, just improve the radiology, or the surgery will automatically be improved, the fear of complication will improve. Now see, another thing that I told you, if you remember, that the caudal end of the supraorbital cell is formed by, hello?
Oh, yeah.
Caudal end of the supraorbital cell is bordered by anterior ethmoidal artery. So now, as long as I am working to the level of the supraorbital cell, my anterior artery is behind. Okay? Again, no worries. See now, I am opening up this supraorbital. Why this cell is important? Why do we give so much of importance? Reason being, this cell, if it is bigger, it can narrow the frontal sinus outflow from laterally. See this? And in those bigger supraorbital cells, what we do, we remove the party wall and enlarge the frontal outflow. Can you see that?
Yes.
See, the beauty of debrider is it's not pulling anything. Simple. See my osteoma? It is dying to be out. See this? See this? Complete cell. Laterally, see this? It is still narrowing the frontal sinus. See this from laterally. One must think of doing the best job to the patient. The first chance is the best chance. See that supraorbital?
Yes.
And see this party wall. If I remove this party wall, imagine how big would be the frontal opening. Can you see? Sinus surgery is surgery of landmarks, and you can do all this work only if you have visualization. See, everything is important. Had there been a lot of bleeding, then we would not see all these structures so clearly, and surgeon, if tries to go for a good work, complete work, giraffe, will ultimately land up with complications. And you can see that how big the frontal sinus is. Give anterior-posterior only when I ask giraffe. The side one is when I ask for the side one. Now see, I will further widen this by removing this party wall. See that? See this? It may strip off the mucosa. Stop there and take the help of the debrider in case some unwanted mucosal stripping is taking place. See this? Yes, yes. I will flush it completely. Which blade you are with?
120 चाहिए 120.
See now. See the supraorbital cell going high up. See this? We train all these patients once we open up all these sinuses to douche with the steroid solution in the post-op extensively, so this mucosa gets the steroids, topical steroids, and gets normalized, and no need of oral steroids. And that is possible when you have this kind of access. See finally, see my osteoma. Yeah. You don't need to do anything to it, it will come out. So don't get terrified by these osteoma. Osteomas are more common in the frontal, we have seen. And again, the access, it's not removal which is difficult, access, that's why we do variety of draft procedures for this access. We do draft for many regions now, tumors for the anterior skull base, for the CSF leaks, the benign as well as malignant tumors sometimes, osteomas, and all these complex sinusitis, revision, massive fungal disease. So draft is important to learn, and that what we why they are changing, Gaurav? Gaurav, tell them to keep only endoscopic. Who is asking them to change every time? See this? That's the complete. See this? What I have done is a type 2A draft. Type 1 is when you just widen the frontal recess outflow. Type 2 is when you widen the ostium to its limits. 2A. 2B, if I remove this complete anterior wall up to the lateral limit and the anterior limit, ipsilaterally, that will be draft type 2B. And if you do 2B on both sides with removal of the nasal part of the nasal septum and intersinus septum is draft 3 or modified endoscopic Lothrops, which Lothrop described 100 years before Lothrop did it open. Now can be done endoscopically. See, I want to flush this posterior table completely. Giraffe.
All A and all B for the morning session have not yet uploaded their presentation. Kindly upload your presentation in the preview room group for smooth continuation of services. Thank you.
Now see the completely flushed picture of the frontal sinus. And that is what a frontal sinus work is called for, and we should aim in every case so that the patient will not have any more problems in the post-op. What do we want to give with this surgery? I told you the aim before, to give access to the irrigation. Access to the irrigation, that's it. And removal of this inflammatory load. That are the two indications. Don't tell your patient that get sinus surgery done, you will be all right. That's the biggest joke. You need to convince them why we are operating and what is the outcome we are expecting, what we are going to achieve with sinus surgery. Ultimately, the patient needs to be involved in the treatment to get the optimized outcome. So up and over. So instrument क्यों उठा लेता है यार? जल्दी में क्या? See this? So that was my the frontal work. Now we come to the point with what we are discussing. Where is our anterior ethmoidal artery so far? That's why I told you, don't get terrified with the anterior ethmoidal artery right from the beginning. See, anterior ethmoidal artery will be at the caudal end of the supraorbital recess. Now simple, see this. I'll tell you all the landmarks I mentioned during radiology for the anterior ethmoidal artery. The first landmark is the supraorbital recess. Okay?
Yes.
Here is the supraorbital recess, this one. This 70 degree is the most versatile telescope. I'm still using the 70. See this, that's the floor of the bulla. Yeah, we call it as a shelf of the bulla. I'm just removing this shelf to show high up. Now, this was the part after removal of the anterior wall. And now what is see there behind? Can you see something? Yeah, boss, just यार आप लोग ना कुछ भी ध्यान नहीं रखते हो कि ब्लेड कैसे लगानी है. यू आर इन माइक्रोनिक ना, क्या सही लगाई हो देखो. That's a very important point. See this, the bulla I opened, this anterior wall. See, I am removing this anterior wall. Can you see something behind? See obliquely going structure? What is that? Artery. So now see the relationship here. Retrospectively, what we discussed. This is the anterior limit of the attachment of the bulla over the skull base. Now this bulla was here like this, which I opened from here. And now see the artery is so well protected by it. So that is the philosophy behind intact bulla approach, that if you keep the bulla intact, your artery is automatically protected. Number 2, that is your supraorbital recess. See this? See going laterally? And immediately caudal to it is anterior ethmoidal artery. Okay? So now see the centimeters anterior to it. Centimeters anterior to it, right from the beginning where we are working. And if a surgeon unnecessarily get terrified by the anterior ethmoidal artery right from the beginning, how can he do? See this? There is no need to. This is in the posterior most part of the anterior ethmoid cavity, anterior ethmoidal roof, where the anterior ethmoidal artery runs. Can you see this? So that's what I told during radiology also, that must correlate where the anterior ethmoidal artery goes in the posterior most part of the anterior ethmoidal cavity. See this vessel? See this vessel carefully? And that is the posterior limit of this supraorbital recess. See that? Now give me reverse. I'll just remove this septation. This artery, see this? It is taking origin from the ophthalmic in the orbit and then coming out here along the skull. I told you this patient having good pneumatization of the supraorbital recess, the artery was supposed to be prominent. And this is what here with us, at reverse they are. डिफिकल्ट आदमी हो तुम यार. गौरव, see now with the reverse blade again, because I want to remove in this direction. See my cutting edges? I want to remove this redundant mucosa and redundant septations under vision. My artery is there, I am working right on the vessel. See this? To get these septations out. See this? Don't get terrified with the vessel. The vessel is very well protected in the bone. This vessel we coagulate intensely in all the endoscopically when we address the olfactory neuroblastoma, meningiomas, all these tumors, as this is the principal blood supply for all those regions. And in our series of now more than 70 cases of olfactory neuroblastoma which were done endoscopically, this is something, this approach endoscopy has revolutionized, transcribiform approach. See now? That's the anterior ethmoidal artery. Now the three landmarks I told you to correlate with the anatomy of the anterior ethmoidal artery is number 1, this supraorbital recess. Number 2 was the bulla. And number 3, see this is what? Now after removal of the bulla, this is the ground lamella. See this is the first part of the turbinate, turning into second part to get inserted on the lamina. Can you see this? This is bulla. And see where the bulla is going high up. So at the upper limit of the bulla, the anterior ethmoidal artery is few millimeters anterior. And believe me, this is more constant. See, God has given us so many landmarks. The important thing is to use them optimally. We know the bulla, the ground lamella separates the anterior from the posterior ethmoidal group. Anterior ethmoidal artery being in the posterior most part of the ethmoidal cavity, the moment the artery ends, the posterior ethmoid will start, and where the posterior ethmoid will start? It is divided by the ground lamella only. The ground lamella has to be there behind the anterior ethmoidal artery. That's a simple thing. If we pick up this anatomy, we can certainly identify and protect this vessel.
Satish,
Yes.
can we finish off this your posterior ethmoid, this sphenoid, quickly because Janki already ready with his case.
Yes, yes, fast. Now last 10 minutes.
Okay.
See now?
Yes.
That's the work I did with the 70 degree. Now I am changing to 0 degree. He can come on the other side he wanted to do. Can you ask him?
Should I ask?
Yeah, if the time is because the issue. No? He can come and do other side. No? He was asking me. Hello?
Yes, sir.
Now I am back with the 0 degree. See this. See the picture, all mucosa, turbinate, everything in place. Now the next thing, the last two things left are the posterior ethmoids and the sphenoid. This is the shelf of the bulla which I am removing, the lowermost part. Now before going into that, I will develop a very, very important landmark, and we call it as a life-saving landmark. See this? What I am trying to see here at the medial wall of the orbit inferiorly, at the inferior medial angle, that is the roof of the maxillary sinus. Can you see? Yes, yes. Ask him to get ready if he wants to bring some other instruments. I'll just finish up quickly. Hello?
Yes, sir.
Now, what is this landmark? This is the roof of the maxillary. This we call maxillary line is a life-saving line. I'll tell you the reasons. The single landmark can prevent you from other problems that are most dreaded, and that happens while doing posterior ethmoidectomy. You know the Mosher, what is stated 100 years back. The easiest way to kill a patient is ethmoidectomy, and there is a reason behind it. Because while doing posterior ethmoidectomy, I know this is ground lamella. Behind the ground lamella would be the posterior ethmoids. Okay, you can go ahead with the posterior ethmoidectomy, but
Endoscopic picture, please.
बोल देना इसको चेंज क्यों करता है? See, behind this would be the posterior ethmoids.
Yeah.
And the concern while doing posterior ethmoidectomy is, if you don't know the posterior limit of posterior ethmoidectomy and go accidentally into the sphenoid and then start working, can be a disaster. So what we suggest here is to develop some landmark to know our posterior limit of posterior ethmoidectomy. Okay?
Yes.
One of the landmark now what I am taking into consideration is maxillary line. In this line, now we have to enter into the ground lamella first to go into the posterior ethmoid. Now what should be the level? If I go into the ground lamella here, what can happen? What can happen? I'll be inside. Okay? I'll be breaching the skull base. So the best way to make an entry into the posterior ethmoid is at the level of this maxillary line. Where? This is the first part of the turbinate. This is the second part of the turbinate at the beginning of the second part, medially. See this? Just simple entry you can make with a microdebrider, little bit widen it. That's a very important anatomy. Now, why I told what I am concerned with is the accidental entry into the sphenoid. That I will never want, and this is what that's one of the important aspects in sinus surgery. That's one of the most important concern. See what I will do before doing a posterior ethmoidectomy. I will find out my posterior limit of posterior ethmoid. Okay?
Yes.
How come? See where you made this opening, go medially into the between the superior and the middle turbinates. See that?
Yes, yes. So go as immediately as possible.
Can you see something?
Yes, yes, I can see that. Yeah, very nice. Yeah.
What is that?
The superior abdomen.
What is that? That's the superior.
Abdomen.
Can you see?
Yes, yes.
Just remove the part of the superior turbinate. बंद हो गया. Inferior part of the superior turbinate, and what you will find between the superior turbinate and the septum. See here, where we are. Can you see?
Yes.
This is superior turbinate.
Sphenoid ostium.
So I will remove this lower part of the superior turbinate here.
Yes.
Only the lower part.
Lower part, yeah.
See carefully. See carefully.
Yes.
That's the superior turbinate. Can you see? This is superior turbinate.
Yes.
I am not concerned much for doing a posterior ethmoidectomy first year. My concern is I want to find a posterior limit. See this. Now at this point you have to take another landmark in view, that is septum. Can you see this septum? This is superior turbinate, this is septum, and in between would be the ostium. Now, section periosteum. Now at what level? If I try to go here to seek for the ostium, what can happen?
Surface.
See, this ostium is never at the level of the floor. It is relatively at a higher level, and the plenum is not far away, far off. So, if I try to go high up, I can breach the plenum. So, the best landmark to go into to further to open this ostium is, see this is my life-saving landmark. Always go, first of all, see, I tell you, the simplest way, yes, it is, I can see. The simplest way is not to go above the level of this life-saving landmark. That is the highest limit. And second is go flush with the septum. Can you see this? I am into the ostium. See that? Go flush with the septum. See that? And don't go above this level. Having seen this sphenoid ostium, that is my posterior limit of posterior ethmoidectomy. So now I'll expose this sphenoid ostium to keep under visualization by removing this inferior part of the superior turbinate. Can you see this?
Yes.
Now my ostium is in view.
Yes.
Now I will carry out my posterior ethmoidectomy. See what this cell is. Very often we can miss this pneumatization here sometime. There is a Heller cell if it is deeply pneumatized. See this?
Yes.
I am excentrating my post-ethmoidal cells without any fear.
Yes.
The most, the important part of the surgery you can carry out very fast, knowing the fact that my posterior limit. I will do anything in this corridor between the septum and the in the septum and the lamina, the septum here and lamina papricia, up to the level of the sphenoid ostium. See this?
Yes.
I will never cross it at this time. If I cross it, I will be in the sphenoid, and if the anatomy is unfavorable inside, like ONOD situation and some exposed nerve or vessel, and accidentally if I enter without knowing this fact, can be a disaster. Now, what does this mean? If I keep this ostium, if I keep this ostium in view and do anything anterior to it, I can never damage the optic or carotid. As simple as that. Even in the ONOD situation, any given situation, the optic nerve would never come out of the orbit anterior to the plane of the sphenoid ostium. Okay? This is very clear. See, this is the nature's anatomy, and we are just taking the advantage of that. See this endoscopic surgery, maybe sinus surgery, skull base surgery, this requires a thorough understanding of the anatomy. That's why we advocate more and more cadaver dissections to get used to identifying anatomy, to get used to instrumentation. Now see, see this? Where is my, मत डाला कर, जब डालने का टाइम है जब डालता नहीं है. See this. This is my ostium. See what is there here. Could be optic nerve here. But see the level. See the level of the ostium. Even if there is onody, and if you limit, yeah, looks like, yes, yeah, that looks like the optic nerve. Now see, even if it is onody, doesn't matter. If you have the safeguard, the anterior wall of the sphenoid and the sphenoid ostium here, if you don't cross this limit behind, see this? It is far behind. You cannot injure even if it's onody. Now imagine, had we not been having this safeguard, had we been doing this post-ethmoidectomy here directly and keep going behind, not realizing that where we are, where the onody is, we can easily hit this skull base and would be a disaster. So we need to understand this fact, that's why we call this as a life-saving landmark. Now I will just clear all these septations up to the turbinate here. See this? My corridor, and this is my lateral corridor. See this? That's the full-blown picture of the onody here. So with this technique, whether there is onody or not doesn't matter at all. Now see the cells in the floor. Can you see? Excentrate all these cells in the floor, they become the source of problem. See this? The floor. Can you see? Complete excenteration of the floor. Now see, that was your part of the ground lamella which you opened. That is the skull base. Now this is the anterior artery here. That is the posterior skull base. Now this being the optic nerve, the best landmark for the posterior artery, which is most of the time passing through the thick skull base, is not visible, not prominent. Huh? What is the best landmark for the posterior artery? 5 to 6 millimeter anterior to the optic nerve. See here. That looks like, in this case, the glimpse of the posterior artery at this level. Okay?
Say it again, so you could get it.
Few millimeters, 6 millimeters anterior to the optic nerve. Optic nerve is most easily identified in sinus surgery, and if you stay 5-6 millimeters anterior to it, that is the probable location of the posterior artery. That's a more reliable landmark than you take the landmark like distance from the anterior artery, which is never reliable, because that varies according to pneumatization. This is a more constant landmark. Okay?
Yes, good.
See now the corridor. Now having removed this kind of a disease, see that with this exposure for the douching, everything what you douche will go to the sinus mucosa. See that? And if you have cleared all the septation, you have practically not left anything for the future surgeon. Okay? If your patient douches properly, if you take care of the pathophysiology and other comorbidities, you can give an indirect guarantee to the patient, boss, you will never need a formal sinus surgery, because there is nothing is left.
Looking like a radical mustard cavity.
Yeah, but not, it is functional. See the mucosa.
Modified radical.
See now what I am doing? Widening the ostium. Now you can do with many instruments. You can use a mushroom punch. You can use a Kerrison punch. If it is thick one, you can even use a drill. I can, in the thin septa, even remove with a debrider, taking care. Just stick to the anterior wall, not to go behind, blind inside and debriding anything. See this? What I am doing? Using the Kerrison punch. See, staying right on the wall. Yeah. See this?
Yes.
Gently. It's a very good tool if you use it properly. It's a very safe instrument, as what you need to know is what you are punching. See, that is the interior of the sphenoid sinus.
Yeah.
No, first give me the forceps. Give me the forceps and give me a wash. See, that's the final part on this side. So this is what the sinus surgery we believe now, and we reached to this technique after having seen our own failures, so many things. We went through the literature and almost followed more than 3,000 articles, and in our thousands of cases now, our results are much better. But still there are a lot of comorbidities. Still there are a lot of comorbidities even if you do a good work and the patient suppose has a leukotriene problem like aspirin sensitivity, you operate 100 times, it is going to come back because the high leukotriene level. So you need to address all the possible comorbidities. It's like a syndrome, it's not a mechanical disease that you open the sinuses, patient will be all right. It's a joke. See this? See, my sphenoid opening is adequate to allow the solution to reach inside. Okay? So this was all about the sinus surgery on this side, and now Dr. Janki Ram will take over and demonstrate on the other side.
Wonderful and beautiful disposition of the surgery.
Joseph, thank you so much once again, and all thanks to the big boss, our elder brother, Dr. Sanjay Agarwal, and his team, and the team AOICON as a whole for giving this opportunity. And it's always a really an honor to be in our own national body meeting. Thank you so much. Thank you once again, everyone, for the patience. Thank you. तो वो मेरा सिल डाल दे कहाँ है? अरे जी सर